Hi everyone, welcome to our module on disorders of peripheral nerves and muscles. In this video, we're going to cover about disorders affecting the peripheral nerves and neuromuscular transmission. We'll start with nerve injury, then move on to hereditary neuropathies, then study about critical illness neuropathy, and finally, we will end up with some neuromuscular junction disorders. I'm happy to let you know that we have now officially collaborated with UWorld Medical. You can get a flat 10% off on their medical library subscriptions using my code WARUN10. This medical library is highly integrated to UWorld Q banks, all step 1, step 2, step 3, and clinical Q banks. And this turns every Q bank question help us with deeper understanding. They've come up with an AI-powered tool called as You Ask, where you can ask any kind of doubt from their text. You can learn faster with an integrated all-in-one content, and this is a highly organized resource. You can have a glimpse of their medical library. You can look at their page using my link in the using a link in the bio, and you can get a flat 10% off using my code WARN10. You can get flat 10% off on the medical library and bundle QBank packages. This lecture series is provided free and is open access for everyone. There are no paywalls or mandatory fee. We do not receive any kind of funding from any organization. If you find it useful and wish to support its continued development, you can contribute us with the link that is on the screen, and that's also pinned in the description. You can also pay to us with the QR code on the screen. This QR code is only for audience from outside India. This is a PayPal QR code. So, peripheral nerve injuries are classified based on how much structural damage has occurred. The two key things that we need to assess are whether the axon is damaged and whether the surrounding connective tissue layers are intact or not. These things determine the prognosis and recovery. Peripheral nerve injuries are classified by severity based on axon damage and sheath integrity. So, understanding the type and the severity of injury is a key to prognosis and management. There are three main types. So, neuropraxia is the mildest, where only myelin is affected, whereas axonotmesis involves axonal damage but preserved structure. Neurotmesis is complete nerve disruption, and as severity increases, recovery becomes really difficult. In neuropraxia, the axon remains intact, but the myelin sheath is damaged. This causes temporary conduction block. Since the structure is preserved, recovery is complete and typically occurs within weeks. Whereas axonotmesis is characterized that the axon is physically damaged, but the connective tissue layers remain intact. This allows the nerve to regenerate, but this process of regeneration is slower and involves degeneration followed by regrowth. The sheaths are intact. The endoneurium, perineurium, and epineurium are intact, and the key process that is involved is Wallerian degeneration, and this is followed by regeneration or regrowth. Wallerian degeneration is characterized, so it's usually that after axonal injury, the portion of the axon distal to the injury usually degenerates. The myelin breaks down and macrophages remove the debris, and this is called as Wallerian degeneration and is essential before regeneration can occur. So firstly, the distal axon degenerates. This portion of the axon distal to the injury usually undergoes degeneration, and there is myelin breakdown. The myelin sheath disintegrates into fragments. Finally, there is clearance of the debris by macrophages. So macrophages infiltrate and remove the cellular debris and myelin fragments. So loss of distal nerve conduction until the axon regenerates towards its target is the key result. Proximal to the injury, the neuron undergoes structural changes. The cell body swells, the nucleus shifts towards the periphery, and protein synthesis machinery reorganizes. This reflects the neuron preparing for regeneration. So this is called as axonal reaction. After axonal injury, changes occurs in the neuronal cell body or proximal to the site of injury. This is characterized by swelling of the cell body. The neuron cell body becomes enlarged. Nucleus moves peripherally. The nucleus is displaced to the edge of the cell. The cell body is a rough endoplasmic reticulum that dissolve or disperse as the cell shifts to protein synthesis for repair. Swollen cell body with nucleus pushed to the periphery and there is loss of nasal substance. The neuron shifts from normal function to protein synthesis to support axonal regeneration. Finally, in regeneration, Schwann cells form a guiding scaffold for regrowth of the axon. This regeneration rate is slow and is about 1 to 2 millimeters per day. Importantly, this process only occurs or works if the structural pathway is preserved. This occurs only if the sheaths are intact. Schwann cells usually guide the regrowth, they remain intact and form a guiding pathway, also called as bands of Brunner for the growing axon. The axons regenerate slowly, growing towards their target at approximately 1 to 2 millimeters per day. Successful regeneration depends on intact endoneurium, perineurium, and epineurium. Intact connective tissue sheets with Schwann cells, along with the presence of intact Schwann cells, this leads to successful axonal regeneration. In neurotmesis, the entire nerve, including its supporting structure, is severed. There is no pathway for regeneration, so recovery is poor unless surgical repair is performed. This neurotmesis is the most severe injury characterized by complete disruption of the entire nerve trunk, including the axon and all connective tissue sheets. The entire nerve is severed. Axon, endoneurium, perineurium, and epineurium, all of those are completely severed in this condition. And because of loss of connective tissue, there is poor prognosis. There is no anatomical pathway that remains for the axon to regrow on its own. Without surgical repair, these nerve fibers cannot regenerate across the gap. So treatment of this neurotmesis is surgical repair, also called as neuropathy, where there is microsurgical reconnection of the nerve ends to restore the continuity and allow potential axonal regeneration. Charcot-Marie-Tooth disease is the most common inherited peripheral neuropathy. It is usually caused by duplication of a gene involved in myelin structure, leading to progressive nerve dysfunction. So, this CMT is a group of inherited disorders that affect the peripheral nerves, and this leads to progressive weakness and atrophy primarily in the distal limbs. The most common cause of this Charcot-Marie-Tooth disease is the duplication of PMP22 gene, and this accounts for 70% of the CMT1A cases. This leads to overproduction of PMP22 protein, which leads to formation of abnormal myelin, and this eventually leads to slowed nerve conduction. Clinical features usually includes there is progressive weakness and atrophy of the distal limbs. So there is areflexia, reduced raps and deep tendon reflexes. Foot deformity is characterized by high arches, pes cavus, and hammer toes. Sensory loss in a stocking glove distribution. Muscle atrophy, especially in the distal legs and hands. Distal muscle weakness characterized by foot drop, and there is difficulty with dorsiflexion. This Charcot-Marie-Tooth disease is the most common inherited peripheral neuropathy, and this usually follows an autosomal dominant pattern of inheritance. This is diagnosed by nerve conduction studies that shows slowed conduction velocity. Genetic testing confirms PMP22 duplication, leading to CMT1A subtype. Nerve biopsy is rarely needed, and on nerve biopsy, it may show demyelination with an onion bulb appearance. You can read about this Charcot-Marie-Tooth disease on UWorld Medical Library. So this UWorld Medical Library is a highly integrated study resource that divides every single topic, every single important topic, every single concept that is highly organized uh, that makes it easy to read and understand. You can get a flat 10% off on the medical library using my code Varun10. So Patients usually develop progressive wasting of distal muscles, especially in the legs, giving a characteristic stork leg appearance. And it's also characterized by foot drop and high arched feet or pescavus, and these are the classic findings. So, Charcot-Marie-Tooth disease primarily affects the distal peripheral nerves. There is distal muscle wasting characterized by progressive wasting of muscles in the feet, lower legs, and hands, and this is more prominent usually distally than proximally. Stark legs is a classic sign where there is thin waisted lower legs with prominent ankle bones. Features includes foot drop. There is weakness of ankle dorsiflexors, which causes inability to lift the front of the foot. This leads to a high stepping gait. Pescavus with high arched foot due to imbalance of foot muscles. This is commonly associated with CMT. Claw hand. There is weakness of intrinsic hand muscles, which leads to clawing of the fingers. There is difficulty with grip and fine motor tasks. CMT causes distal muscle wasting, stark legs, foot drop, pescavus, and claw hand. The most common cause is duplication of PMP22 gene. Sensory involvement includes loss of vibration and position sense. The disease progresses slowly over years, unlike acute neuropathies. Sensory nerves are involved, and when there is damage to large myelinated sensory fibers, this leads to impaired sensation, especially in the distal areas. This usually follows a stocking glove pattern that is usually seen along with the cases of diabetic neuropathy. Affected fibers are large myelinated or A beta sensory fibers, and this is characterized by loss of vibration sensation. There is reduced ability to sense vibration. Patients may not feel vibration in toes or ankles. There is loss of proprioception. There is an impaired sense of joint position and movement. Sensory symptoms develop gradually over years. This is usually milder than motor involvement but can affect balance and coordination. Critical illness polyneuropathy is a condition that occurs in critically ill patients, especially in those with sepsis. Inflammatory mediators and metabolic changes damage the peripheral nerves. So, CIP or critical illness polyneuropathy is a common neuromuscular complication in ICU patients, especially those with sepsis, multi-organ failure, or prolonged mechanical ventilation. The cause of this critical illness polyneuropathy is inflammation with axonal damage. There is systemic inflammation and cytokine release, which leads to microvascular dysfunction, ischemia, and direct axonal injury. This results in degeneration of peripheral nerves, especially motor than sensory fibers. Risk factors include sepsis, multi-organ failure, prolonged ICU stay, mechanical ventilation, hyperglycemia, use of steroids or neuromuscular blocking agents. Usually, the pathophysiology follows a course of inflammation, which is followed by microvascular dysfunction. This leads to ischemia, and this eventually leads to axonal damage. Clinical features include systemic flaccid paralysis, which is characterized by involvement of proximal more than distal. There is respiratory muscle weakness where there is difficulty to wean from the ventilator, reduced or absent deep tendon reflexes, and also mild sensory loss. This can be diagnosed using depending on the clinical features in an ICU setting. I can do nerve conduction studies, which shows reduced amplitude and normal velocity. EMG may show denervation potentials. These patients develop generalized weakness, often more pronounced proximally. A major clinical problem is difficulty weaning from ventilator due to respiratory muscle weakness. So, this affects both the sides equally. It is more pronounced in proximal muscles like shoulders and hips. There is flaccid weakness of all the four limbs. Proximal growth more than distal. Key issue in critical illness polyneuropathy is there is difficulty weaning from the ventilator due to respiratory muscle weakness. Coming to neuromuscular junction disorders, now let's try to understand about uh, them as a whole. So these disorders affect the transmission of signals from the nerve to the muscle. So the problem is not the nerve or muscle itself, but the communication between them. So a group of autoimmune disorders that impair the neuromuscular communication between the nerves and muscles at the neuromuscular junction. So they are usually mistakenly, it's usually characterized where the body's immune system mistakenly attacks the components of neuromuscular junction. This leads to impaired transmission, which leads to muscle weakness, fatigue that typically worsens with use and improves with rest. Examples of neuromuscular junction disorders includes myasthenia gravis, Lambert-Eaton myasthenic syndrome, and botulism. These are autoimmune conditions that disrupt neuromuscular signaling, leading to characteristic patterns of muscle weakness. In myasthenia gravis, so in this condition, antibodies attack receptors on the muscle side of the junction, reducing the ability of the muscle to respond to nerve signals. And so, this is an autoimmune disorder that usually impairs neuromuscular transmission by targeting acetylcholine receptors on the postsynaptic membrane. Autoantibodies are formed against the acetylcholine receptors at the motor end plate. There is decreased number of functional receptors, which leads to decrease in neuromuscular transmission. This results in muscle weakness that worsens with activity and improves with rest. Clinical features includes fluctuating muscle weakness, which worsens with repeated use and improves with rest. Commonly affects the ocular muscles, bulbar muscles, and proximal limb muscles. It is usually associated with thymic hyperplasia or thymoma. So this is a key point that we need to remember with regards to myasthenia gravis. You can read about this myasthenia gravis on UWorld Medical Library. So this is highly organized into introduction, pathophysiology, epidemiology, clinical presentation, diagnosis, differential diagnosis, management, and complications. So this UWorld Medical Library is a highly organized study resource that is easy to read and understand with simple language, and also has images and tables. And you also have a new feature called as You Ask, where you can ask anything. The hallmark of myasthenia gravis is fatigable weakness. So symptoms worsen with repeated use and improves with rest. Eye muscles are commonly affected first. So ptosis, there is drooping of the upper eyelid, diplopia, there is double vision, uh, and also it is characterized by generalized muscle weakness, which fluctuates throughout the day. So fatigability is characterized by worsening fatigability with repeated usage. After prolonged usage, there is worsening, and this improves with rest. Strength returns back after rest. Myasthenia gravis is characterized by fatigable weakness. It is worse with use and improves with rest. Myasthenia gravis is strongly associated with abnormalities of the thymus, including tumors and hyperplasia. Evaluation of thymus is essential in cases of myasthenia gravis. Thymoma is present in 10 to 15% patients with myasthenia gravis. This is associated with more severe disease and often early onset. We always need to evaluate thymus in those patients who suffer or who are diagnosed to have myasthenia gravis. Uh, we usually need to do a CT test to assess the thymus. So myasthenia gravis is strongly associated with thymoma. Always evaluate the thymus in all patients with myasthenia gravis. Lambert-Eaton myasthenic syndrome is characterized by antibodies which affect the calcium channels on the nerve terminal, reducing the release of neurotransmitters. So there are autoantibodies against the calcium channels, and these target the voltage-gated calcium channels where there is decreased calcium influx, which leads to reduced acetylcholine release, and this results in proximal muscle weakness and fatigability. This Lambert-Eaton myasthenic syndrome is a presynaptic disorder which is caused by autoantibodies against calcium channels, P by Q type. Lambert-Eaton myasthenic syndrome, unlike myasthenia gravis, so in LEMS, weakness improves with repeated use. This condition is often associated with an underlying malignancy like small cell lung cancer. Like myasthenia gravis is associated with thymoma, this LEMS is usually associated with small cell lung cancer. The weakness worsens with use in myasthenia gravis, and weakness improves with use in Lambert-Eaton myasthenic syndrome. Now let's just try to quickly revise whatever we have learned in this module. So, neuropraxia is the mildest form of peripheral nerve injury, which is characterized by simple demyelination, whereas axonotmesis, there is Wallerian degeneration with intact connective tissue sheets. So, it usually carries a better prognosis when compared to neurotmesis. In neurotmesis, there is complete severance of the nerve along with severance of the connective tissue sheets, the endoneurium, perineurium, and epineurium. So there is an complete severance which leads to worse prognosis. And for repairing neurotmesis, we need to do it using surgical repair. It's also called as neuroraphy. So this is a microsurgical procedure. Myasthenia gravis worsens with use, and Lambert-Eaton myasthenic syndrome weakness usually improves with repeated use and worsens with rest. This is the end of this module. I hope this video helped you. This completes peripheral nerve and neuromuscular disorders. In the next video, we'll move into headache disorders. Till then, bye.